Good evening, this is Fraser Cobb. Thank you all very much for joining us for tonight's webinar. We are just letting everybody in to the main program, so let me just do a few housekeeping items here to make sure we are all set and that we have everybody on board that wants to be on board. Again, thanks so much for joining us for tonight's program. I really wanted to start with a quick thank you for tonight's speaker, Megan Heiden, who was willing to do this program on short notice for us. These OSHA regs just came out just recently, and given the importance of them and the need to get this information in the hands of our members, we reached out and asked if they could throw something together for us. So we're really looking forward to tonight's program because of the timeliness of it, as well as the urgency for y'all to understand the regulations and make sure you're moving towards compliance over the coming days. So again, I'll do a formal introduction to Megan here in a minute, but wanted to start by publicly thanking her for her willingness to do this tonight. As far as housekeeping goes, we are going to adhere to Zoom etiquette. So many of you are way too familiar with Zoom at this point. So we ask you to keep your lines on mute unless until we get into the Q&A session later on in today's program. At that point, we'll be able to do a little bit of Q&A, and I'll moderate with our speaker tonight. So again, stay on mute if you want to hide your camera too, so we can use all of our juice and power to hear the presentation. That would be fantastic. You do have the chat panel as well, so you can type in questions as we go through the content. And then again, I'll work with Megan to moderate some Q&A at the end of that. We are recording tonight's program, so we'll send y'all a copy of the recording as well with her permission. We did also send out a number of documents that they compiled for us for supporting documentation for the content for this evening. I emailed that out several hours ago. If you did not receive it, let me know and we can send it out to you again. Also, we are going to post this in the members only section of our website too, so you can access all of those supporting documents as well as the program from tonight. With that, I'm going to be quiet and do introductions and move into the meat of tonight's program. So again, the focus of tonight's event is to discuss the OSHA temporary standards for healthcare entities that were released recently. Our speaker tonight is Meg Heiden, who is with the Smith, Hulsey and Busey law firm in Jacksonville. Meg is an experienced advisor and litigator working in the firm's healthcare, labor, and employment and litigation practice areas. For more than a decade, she has supported clients in managing a broad range of complex legal issues in employment and healthcare matters. With her broad range of healthcare experience, she helps clients avoid or respond to litigation arising from their transactional and healthcare regulatory obligations. Her practical knowledge of the healthcare industry's nuances allows her to bridge the traditionally siloed litigation, transactional, and regulatory practice areas to provide holistic representation that considers all of her clients' competing priorities. Meg also enjoys providing legal support for her clients' quality improvement, patient assistance, and community outreach programs. So we're really pleased. I was just a short snippet of her bio. I want to save as much time as possible for her to dive into this complex area and these brand new regulations for us. So with that, Megan, thank you very much for joining us tonight. And I'm going to turn the program over to you and go on mute.
All right, thank you very much, Fraser, and thanks to the group for the opportunity to come talk about this very exciting topic. I have included a great deal more information on this slide deck than I would typically include in a presentation. I don't plan to read it out loud to you guys or anything like that, but this stuff is really technical, very nuanced, so I didn't want to risk leaving out things that you need to know about. I will say that I did not go into detail about some of the record Oh, am I muted?
You're back now. Sorry, that was my fault. I hit the wrong button.
Okay, so I won't go into a great deal of detail about all of those reporting and record keeping requirements or the mini respirator program. I recommend that you look at those as you're finalizing your programs, but I'm hoping that at least a few of you will still be awake to hear and ask questions at the end of the presentation, so I'm not going to go into detail on everything. So let's start off here with why are we here today? What are we talking about? Well, we're here because nobody likes acronyms more than like lawyers and bureaucrats. So we're here because OSHA, which is the Occupational Safety and Health Administration, that's a federal agency, has promulgated a set of emergency temporary standards addressing the manner in which healthcare employers must configure their workplaces to protect healthcare workers from occupational exposure to COVID-19. Normally, when OSHA is planning to propound a set of standards, they go through what we call a notice and comment period, which is they publish, this is what we think the standards should be, and then there's a period of time for the public and interested groups to comment, to raise some issues, anything that needs to be sorted out or clarified or is going to cause problems that OSHA hasn't thought of. And then all of that gets baked into a final regulation that is released and implemented. Because OSHA is treating this as an emergency standard, the notice and comment period will happen during implementation of the emergency standards. So these were published on June 21st. The majority of the requirements go into effect on July 5th. That means you have to be compliant by July 5th. The remainder of them will go into effect later in July, and the notice and comment period will run now, and ultimately a final rule will be implemented down the road some months from now. So that's why we're here. And why is OSHA doing this? Well, they're doing it because in January, President Biden wrote an executive order, which is included in your materials, that noted that healthcare workers are on the front lines of exposure and risk in the pandemic. And in order to make sure that the federal government is doing something to protect that class of workers, the president directed a number of different federal agencies to take steps, one of which was OSHA. And so that's why OSHA has promulgated these emergency temporary standards. Now, why is this a big deal? Well, this is really a game changer in several ways that I think may not have the best impact on healthcare providers that are covered. So first, as you'll see as we go through the slides, OSHA has included some very technical requirements for things like PPE and procedures during different in different patient care areas and different types of workplaces. Those are not going to be, you're not going to be able to change those nimbly as the pandemic evolves. You're going to be stuck with them. So that's challenge number one. Challenge number two is that it brings the regulatory enforcement authority of the federal government to bear on these workplace practices. So employees will be able to report non-compliance to OSHA and trigger an OSHA investigation into your workplace safety practices. Creates a new obligation for covered employers, and we'll talk about that in a minute, to provide paid sick leave to employees who get COVID-19 or who have to be isolated from the workplace because of a COVID exposure. And it's really notable, not only is this a new paid leave requirement, it's regardless of whether the employee's COVID-19 case is contracted in the workplace or in the community. We talked a slide ago, I mentioned that this is subject to challenge in the federal district courts. I do think that because this paid sick leave right goes beyond the bounds of what would typically be traditionally included in an OSHA regulation, that we're likely to see some litigation activity around that. So again, you have to comply with it because it is an emergency standard, but stay tuned for how things play out. And then the last item that makes it important is that there are very robust anti-retaliation provisions in this OSHA regulation. And as those of you who work on the employment side of healthcare know, every time you have an anti-retaliation provision, you have new avenues of liability. So the first thing that everybody needs to figure out is, does it apply to us? Does it apply to our business? And One of the things that I included in the packet of materials is a somewhat confusing but fairly nifty flowchart that OSHA has prepared that lets you answer some questions and figure out what parts of it are going to apply to your workplace. So I don't have enough confidence in my Zoom abilities to try to put that up on the screen because I may never get back to the presentation, but please see that out of your materials. It does streamline this discussion into something that is a little bit less difficult to follow. So as is typical, the OSHA starts by casting a very wide net, and then they identify specific types of entities and environments that will be carved out of the regulation. So the default is everybody. Any setting where any employee provides healthcare services or healthcare support services is covered by these regulations. And then we get into the exclusions. Should you need to, because we have a bunch of lawyer bureaucrats here, there are a number of pages of definitions that define terms that you probably already know the meaning of, but it does talk about healthcare services. That includes dentists, it includes orthodontists, it includes emergency medical personnel, home health, hospice care, patient transport, healthcare support services. Those are all the kinds of things that you would think of, including food services, housekeeping, laundry, medical waste handling, cleaning, reprocessing, all that kind of thing. But then who's excluded? Okay, well, if a first aid by a non-healthcare provider employee, if one of my colleagues gets one of those terrible hemorrhaging manila folder paper cuts and I have to wrap a paper towel around it and help bandage it, because I am unqualified to provide healthcare services, the fact that I provided that first aid in our office is not going to bring us under this regulation. Retail pharmacies don't qualify. And then we get into the screening and vaccination exceptions. So non-hospital ambulatory care settings can be excluded if, number one, all non-employees are screened prior to entry, and number two, people with suspected or confirmed COVID-19 are not allowed to enter. So if you are, a cardiology practice and you can screen every single person that walks in the door of your office, and because of the nature of your practice, you require any patient who is presenting with COVID-19 symptoms to, you don't allow them to enter, you require them to reschedule, you can avoid being subjected to this regulation. Now, unfortunately, while they gave us lots of definitions of things like face masks, the government did not tell us what suspected COVID-19 means. We know what known COVID-15 means. That's somebody who's tested positive or been diagnosed by a healthcare provider. We don't know what suspected COVID-19 means. The definition does tell us that COVID-19 symptoms mean the following: fever, chills, cough, shortness of breath or difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion or runny nose, nausea or vomiting, and diarrhea. So I think the safest bet as you're thinking through this exception is to probably use those criteria as the screening questions. And if the patient answers yes to any of them, that person could be treated as a suspected COVID-19 case, although we know that the odds at this point are not great that they would actually have COVID. You might treat them as a suspected COVID case and not allow them to enter, and thereby avoid having to comply with this regulation. The next exception is this well-defined hospital ambulatory care settings. So if you are in an outpatient day surgery center or an imaging center that is part of the hospital, but that is not part of the inpatient unit hospital, you may be exempted, that workspace may be exempted if all of the employees are fully vaccinated and all non-employees are screened prior to entry, and people with suspected or confirmed COVID-19 are not allowed to enter. And we'll come back and talk about that all employees are fully vaccinated later, because that's not an easy issue, as you may know. So home health care. Similarly, you can be exempt if all of your employees are fully vaccinated. All non-employees are screened prior to entry. Now, it's not clear, but I think there we have to assume that entry would mean into the home, into the location where the home health services are to be provided. And in that instance, I think you're talking about having to look at and screen anyone who's present in that environment. And that you don't enter if people with suspected or confirmed COVID-19 are present. If you have healthcare support services that are located separately from your patient care location, those aspects of your business can be exempted. So if your IT people are offsite or your billing people are offsite, you can avoid having to comply in those workspaces. And telehealth performed outside of a setting where direct patient care occurs. So if telehealth at your office is you going into an empty exam room or into your office space within your practice office, that probably is not going to be good enough to exempt you from compliance. But if you provide telehealth services from your home, you don't have to try to comply with this regulation in your home or in that area in which no patient care is taking place. So here's the fine print. There's been a lot of discussion about occupational mandatory vaccination policies. And for a long time, many people believed that an employer could not require employees to become vaccinated because the 3 vaccines currently available are not fully FDA authorized. They are covered under an FDA emergency use authorization. The EEOC a couple months ago clarified that for us, and that's another acronym, Equal Opportunity Employment Commission. The EEOC came along and said, let's be clear here, an employer may require employees to be vaccinated with one of these 3 vaccines covered under the emergency use authorization. But of course, that is subject still to employees who are entitled to a medical exemption under the Americans with Disabilities Act and employees who are entitled to a religious exemption under the religious anti-discrimination laws. So, and some of you all may have seen actually a kind of a landmark case just last week that a hospital in Houston terminated the employment of, I believe, 70 plus employees who either resigned or were terminated for refusing to comply with the mandatory vaccination policy by the deadline. And those employees filed a lawsuit in the federal district court in Houston, and the district court judge just dismissed that case recently, saying that absolutely employees have a right to refuse vaccination, but they also have a right to seek employment somewhere else. So an employer, the state of the law right now is that an employer can require employees to become vaccinated for COVID with one of the 3 vaccines, but you still have to grant exemptions subject to the other federal laws, just like you would with a mandatory flu shot policy or something like that. So OSHA has taken that into account. They say, okay, we get it. Employers have to give medical and religious accommodations to qualified employees. If you can accommodate an employee in a way that totally protects that employee from exposure to COVID-19, like by having them work in an isolated environment or teleworking from home, then you can still qualify for one of these exemptions that is contingent on having all of your employees vaccinated. Unfortunately, if your employee cannot be accommodated in that way, if it's someone who has a clinical hands-on position, then you are not going to be eligible for one of those exemptions and you will have to comply. And this is where we get into these anti-retaliation provisions, which are overlapping in this kind of instance between disability law and the OSHA law, that you cannot retaliate or be perceived to retaliate against someone because their disability related vaccination exemption requires you to comply with all of these OSHA regulations. So a couple more nuances on this. If you have a minute clinic type situation where it's embedded in a CVS, the minute clinic has to comply, but that doesn't pull the whole CVS store into the OSHA regulations. Where you have emergency responders or other licensed healthcare providers who are going out into the field, your EMTs, the standard applies that the OSHA compliance obligations stay with their employer to provide the proper PPE, the proper policies, et cetera, but they don't extend to the place that these EMTs or healthcare providers are entering into. And then the last one's kind of a one that we're not quite sure what to make of, but in well-defined areas where there is no reasonable expectation that a person with COVID will be present, certain of the standards don't apply, but only as to vaccinated employees. So, all right, if we can't find a way to get out of it, what do we have to do here? Well, you have to make a plan. So workplaces, every workplace that's covered has to develop and implement a COVID-19 plan. The regulation says that you only have to write the plan down if you have more than 10 employees. I don't recommend that. I think anybody who is covered by this regulation, the best practice is going to be writing that plan down, because if you have an occupational transmission, if you have an employee who complains, OSHA is going to come survey you, and you're going to have to be able to tell them all of the who, what, when, where, why, and how about your COVID-19 plan. And if it's not written down anywhere, it's going to be very hard to do that in a persuasive way. So best practice is to write it down. You have to designate COVID safety coordinators, at least one. And those people have to be, as they put it, knowledgeable in infection control principles and practices as they apply to the workplace and employee job operations, which is really a mouthful. But what it means is don't pick somebody who doesn't know anything about the clinical side of your work, because you need somebody who really understands the ways in which these healthcare providers are coming into, and I should say these workers, because we're not just talking about people who provide hands-on clinical health services, but the way that your employees come into contact with outsiders, patients, visitors, with each other, what is feasible, what's not feasible, and that sort of thing. So it may be that you need to have one person from the administrative side and one person from the clinical side, but the people that you put in charge can't just be the ones who were dumb enough to answer the phone when you call. They have to be people who are appropriately selected for this role. So step one is you have to conduct a workplace specific hazard assessment. And that's where we get into having the right people be your coordinators, because they're probably also going to be the right people to sit at the table and drive this hazard assessment. Who's coming in and out of our workplace? How are our employees able to distance from each other? How are they able to distance from our patient? What are the highest risk exposure points here? You need to get input from the boots on the ground, all of the employees who are out there. So again, it can't just be an executive level discussion that is then pushed down on employees. It needs to be something where there's a reasonable sample of your employees participating in this risk discussion. And of course, this kind of thing is going to be really, what it looks like is going to be very different depending on the size of your organization and the type of services that you're providing. If you are going to claim an exemption requiring that is based on having a fully vaccinated workforce, you need to have policies to identify your employees' vaccination status and to document that. Now, some of you may be thinking about the well-publicized vaccine passport law that Florida has. We looked at that statute, and it is phrased in terms of a business is not allowed to deny its services to patrons or customers based upon their vaccination status or inquiring about their vaccination status. So it's a brand new law. We don't have any of the kinds of cases or guidance that we would normally look to make sure that our reading is correct, but I do think that it is meant to apply to a different situation than an employer-employee situation. And so I think at this point, unless there's some different decisions that come down in the future, it is acceptable, and in this OSHA circumstance expected, that if you are going to try to exempt yourself from the OSHA regulation based on having a vaccinated workforce, you need to have that documented. You need to have policies. Another thing to be aware of is that the Americans with Disabilities Act does come to bear to some degree when you ask employees about their vaccination status. The EEOC has told us that merely the act of asking an employee, are you vaccinated? That is not an inquiry into an employee's medical condition of the type that is not allowed under the ADA. But if the employee says no, and you then proceed to ask follow-up questions, then you need to be thinking of the ADA and compliance obligations with the ADA. So just something to bear in mind. You need to make sure you're monitoring to ensure the ongoing effectiveness of your plan and changing it as needed. So plan has to address the hazards, and it has to include policies to minimize your risk of occupational transmission of COVID, to effectively communicate and coordinate with other employers whose employees share the same physical location. So this is, if you think of your acute care hospital scenario, you've got an OR. At any given time, you may have nurses employed by the hospital, an anesthesiologist employed by a private anesthesia group, a surgeon employed by a private surgery group, and maybe even a manufacturer's rep, depending on the kind of procedure. So you have to have policies to make sure that if 2 days later we find out one of those employees in that OR had COVID and was in the OR during the transmission period, that employee's employer communicates with all of the other employers so that their potentially exposed employees can be notified of the exposure consistent with this regulation. And the last one, I think, is one of those examples of something that is troubling in practice as it's written right now. You have to have policies to protect employees whose work involves entering locations subject to the, and this is an error, it should say, whose work involves entering locations not subject to the OSHA regulations, like private homes, and including, your policy should include allowing employees to leave those premises if they're inadequately protected. Now, that's great if your employee is a home health physical therapist. She can say, yikes, there's 25 people standing in your living room. I don't think I can provide physical therapy services safely here. I'm going to leave and we need to reschedule. But imagine that you have an EMT who is called out to a location where there's some kind of a party going on and there's a lot of people there. And the EMTs need to wade through the crowd to get to a sick or injured person who is in need of emergent medical care. Your policy, according to OSHA, has to tell the EMTs that they can leave the premises if they can't be adequately protected through social distancing, but then you've got all kinds of other issues. So make sure that these policies, depending on the type of entity you are, really address those types of nuances. In the EMT example, you could give the employees some specific suggestions and advice on how to achieve adequate protection. Step one is to clear a 20-foot area around the sick or injured person, or that they should, if possible, to transport the patient, if it's not something that implicates stability of the patient, to move this patient outside of the crowded area for the purposes of medical treatment. And so to comply with OSHA, you would want to have leaving the premises if inadequately protected as your last option, but you would want to provide many, many, many more options to avoid the employee having to get to that stage. So patient screening and management. This is for direct patient care. Many of these things are things that you all have probably had in place in the past. Some of you may have dialed back from this degree of environmental control as things have kind of settled down, especially here in Northeast Florida. But this is what OSHA is telling us everybody has to be doing now. Funnel everybody through a limited number of entry points and monitor those entry points. Screen and triage every single person who comes in. Your patients, delivery people, visitors, confused grandma who can't hear you talking to her. Everybody has to be screened. You need to look at the CDC's infection prevention and control recommendations and find the patient management strategies that they recommend for your clinical situation and implement those. And then employers are encouraged to use telehealth where available and appropriate. Encouraged is regulatory speak for if you don't do it, we reserve the right to penalize you later. So to the extent you can be using telehealth, that is what OSHA wants you to be doing. But again, appropriate is an important point. And if your policy is not going to include the substantial use of telehealth, you should really document in your COVID-19 plan the reasons that you are concluding that telehealth is not appropriate for many of these situations based on your type of practice. Standard and transmission-based precautions. The CDC has a delightful publication called Guidelines for Isolation Precautions. It also is excellent for any patients who are suffering from insomnia, but you need to go ahead and implement policies and procedures for adhering to those guidelines. PPE, this is likely to be a big deal at facilities because employees are not going to be happy about some of these things. And this is an example where instead of adopting the CDC's documentation, which would have allowed a simpler updating process as the situation evolves, OSHA has actually laid these requirements out in its own regulations, which means they will remain the law of the land until OSHA changes them. So face masks. Not only do you have to provide all of this PPE to people, you have to make sure that they're using it. Provide and ensure is for all of these elements. And so that means that if if someone wants to complain that Dr. So-and-so refuses to wear the face mask over his nose or refuses to wear a respirator, that is the kind of thing that can result in an OSHA complaint and conceivably a regulatory penalty, although one would hope they would have bigger fish to fry. So face masks while working and changed routinely. Again, nuances of the regulation. I've given you the full document to see what those exceptions are, but respirators and other types of PPE, including gloves, isolation gown or protective clothing, and eye protection for employees who are going to care with patients that are suspected or confirmed to have COVID-19. Now, we've talked about the fact that we don't have a definition for suspected COVID-19. So I think that the best case or the best practice for now, the safest practice, is to treat anyone who has that laundry list of symptoms that we talked about earlier as a suspected COVID-19 patient, which means that if you are, pediatrician's office or a primary care office, and you're seeing patients who have RSV or non-specific flu-like symptoms, you're probably going to need to treat them as suspected COVID-19 patients and make sure that any employee who comes into contact with them has and is using a respirator, gloves, isolation gown, eye protection, etc. You have to ensure use of respirators and PPE during aerosol generating procedures. And I'm not enough of a technical expert to know whether the OSHA's definition of an aerosol generating procedure is broader than that of a medical professional, but OSHA considers a medical procedure that generates aerosols that can be infectious and are of respirable size. That is an aerosol generating procedures. And so they say, as examples, they say Only the following medical procedures are considered aerosol generating procedures: open suctioning of airways, sputum induction, cardiopulmonary resuscitation, endotracheal intubation and extubation, non-invasive ventilation, for example, BiPAP and CPAP, bronchoscopy, manual ventilation, medical, surgical, or postmortem procedures using oscillating bone saws, and dental procedures involving ultrasonic scalers, high-speed dental handpieces, air and water syringes, air polishing, and air abrasion. So respirators and PPE during all aerosol generating procedures, regardless of whether the patient would qualify as a known or suspected COVID-19 patient. If you are performing aerosol generating procedures on persons with suspected or confirmed COVID-19, OSHA encourages you to choose a higher grade of respirator. And like we said earlier, encouraged means you better do it or we're going to be mad at you if something bad happens. So PPE, again, you as the employer, you might choose to provide respirators instead of face masks. If an employee prefers to wear a respirator instead of a face mask, they may supply their own, and you have to allow them to do that. And then you refer back to that delightful guidelines for isolation precautions to tell you what kind of protective clothing you need to provide your employees. So more information here about aerosol generating procedures with possible COVID-19 patients. Only the essential healthcare providers should be in the room. You've got your PPE. If you have a negative pressure room, you need to use that, and then you need to clean and disinfect per protocol. Other workplace requirements: physical distancing, 6 or more feet where feasible, and if it's not feasible, as far apart as possible. Physical barriers, so outside of direct patient care areas, if an employee is not separated from everybody else by at least 5 feet, then you have to have solid barriers to block face-to-face pathways. So if you have a nurse's station where people sit at computer terminals to document, you don't have the space to spread that out. You've got to have those barriers in, and you've got to comply with the cleaning and disinfection protocols as well. You also have to have ample supplies of 60% alcohol-based hand rub or readily accessible hand washing facilities, which of course shouldn't be a problem in any medical facility. I mentioned that OSHA has really gotten down into the weeds. They've got cleaning and disinfecting guidance from the CDC. They've even gone specifically into what they want you to do with your HVAC systems. So I will let everybody spend some time looking at that. Again, it's really going to depend on the size and type of facility that you have, what your obligations are under this, but especially if you're a larger facility, you're really going to want to loop your environmental services people in as soon as possible to figure out what you need to do with your systems. Employee health screening. You need to screen each employee before each workday and each shift. That can be self-monitoring or in person. The next point I noted, if an employer requires a test, they must cover the cost. And as I think back through that, that's not 100% accurate. The takeaway is that it can't cost the employee anything. So if your area has a free testing program available to the public at the health department or at a testing location, and the employee can go there to get a test at no cost, that's perfectly acceptable. The key point is that it can't cost the employee anything. You have to have in your COVID-19 plan and your policies a policy requiring employees to notify you if any of these factors are present that I've listed here. And the good news is that they have not included that whole laundry list of vague and non-specific symptoms in the employee notification requirement. The triggers are a positive test, of course, a diagnosis from a healthcare provider, new loss of taste or smell that's not otherwise explained, and the confluence of both a fever and new unexplained cough associated with shortness of breath. So they have helped us out to some degree by limiting the number of employees who will have to notify you. And then we get into medical removal from the workplace. Anybody who tests positive or meets the screening criteria under the notice policy is immediately isolated. And then you have to look for your return to work protocols. So if the employee is positive, look at the CDC's return to work protocols. If an employee has a suspicion of COVID-19, return to work criteria or a PCR test, again, at no expense to the employee, that has a negative result. And if the employee's medical condition permits it, you may require the employee to work remotely or in isolation if the employee's job is of the kind that would be suitable for that. Of course, if the employee has acute COVID-19 and is ill, you're not going to be able to require them to do work. Exposure notification. So what happens when the employee calls you or the employer of someone else calls you and says, hey, one of those nurses that was in the OR 2 days ago is COVID positive? Well, any employee who was not wearing a respirator and who was in close contact with that positive COVID employee has to be notified within 24 hours. All other employees who were not wearing respirators, who were in the same area of the workplace, a well-defined portion like a floor or a hospital unit or something like that, during someone who might have crossed paths with the employee during the transmission period, but who doesn't meet the criteria for the close contact, those individuals have to be notified. And then if you find out that one of your employees who was present in a place with other employers' employees is COVID positive, then you need to pick up the phone. And so if you're the hospital and you find out that one of your OR staff members is COVID positive, you need to pick up the phone and call the anesthesia group and call the surgery group and call the employer of that manufacturer's rep to make sure that all of those employers can comply with their notification obligations. So then, silver lining again here, OSHA has exempted this requirement for environments where potential COVID-19 patients are receiving services as a matter of course. So if you are in an ICU that takes care of COVID patients, or if you're in the ER treating patients with respiratory symptoms, we assume, number one, that you're already using the highest degree of PPE and transmission precautions. And number two, we know that it's not going to be functional to try to notify and isolate every time one of the patients who is suspected to have COVID turns out to have COVID. So what can you include in your notice? Well, a minute ago I said you get the call that says one of the OR nurses has COVID. Well, that would be a violation of the notice rules because you're not supposed to include the employee's name, their contact information, or their occupation. So an individual with whom you were in close contact has tested positive for COVID-19, and the nature of the exposure, again, close contact, and the dates. So yesterday, an individual with whom you were in close contact has tested positive for COVID-19. And I would suggest that you develop a form of notice. And again, many employers have already done this, but if you haven't, make sure that you have a form of notice that you can just fill in the blank, and that way you don't have to worry that you're failing to convey the appropriate information or that you're including something you shouldn't be. This also, if you're a small group, sometimes we get this question, well, we only have 5 employees and Sally Jane already called the front desk and told everybody that she has COVID, and everybody already knows, so it doesn't matter what I put in the notice, right? Well, it does, because employer confidentiality obligations and OSHA now are telling you that you can't put Sally Jane's name in the communication. So the fact that everybody already knows doesn't give you the right to say it. It's silly, but it's the law. So back to medical removal from the workplace. You got to get these people out 14 days for a close contact, or they can come back after 7 days if they have a negative PCR test at least 5 days out. You don't have to remove someone based on close contact if they are vaccinated and asymptomatic. And again, you can have them work in isolation. Medical removal protection benefits. That's a very nice long way of saying paid sick leave for people who can't come to work because of COVID. So for all covered employers, if you can find remote work for these people to do, you have to keep paying them just like you would pay them if they were coming to work, even if they maybe don't have as much work they can do, normal pay. If the employer if the employee can't come to work because of an exposure, but they're refusing to shorten their isolation period by taking a COVID test, you don't have to provide them the benefits unless their reason for refusing the COVID test is protected by the ADA or a religious belief. And when the employee comes back, it's just like FMLA. If they're out on this leave, medical removal, when they come back to work, you have to reinstate them completely as though they had never been out. For employers with more than 10 employees, you have to pay regular benefits and regular pay up to $1,400 a week until the employee meets return to work criteria. If you have fewer than 500 employees, then you get a break on what you have to pay starting in week 3. The cap goes down to 2/3 of the employee's regular pay, no more than $200 per day. So if you've got over 500 employees, you don't get that discount. You continue paying regular benefits up to $1,400 a week. And if you are in a jurisdiction where there's some kind of a fund that compensates people who can't work because of illness with COVID-19, any benefits the employee receives from such a fund, you get to offset from what you have to pay. For those of you in Northeast Florida, I'm not aware of any such programs at present. So when we look at return to work, look at isolation guidance and the return to work healthcare guidance. OSHA says, somewhat remarkably here, the CDC had written its strategies to mitigate healthcare personnel staffing shortages to change the quarantine recommendations for certain types of healthcare providers to make sure that facilities could stay fully staffed. OSHA says, we strongly disfavor that approach, and it should only be taken as a last resort if the worker's absence would mean there's no longer enough staff, and you've tried everything else under the sun, and you've told all the patients, and you've given everybody extra PPE. The takeaway here is that you really should not do this unless all the wheels are falling off, and OSHA will not be happy if this comes to pass. So vaccination, you have to support vaccination for each employee. You have to give them paid time off to go and get vaccinated and to recover from any side effects that they have after vaccination. Because they have phrased this in such a broad way, unfortunately, if an employee gets Guillain-Barré after a COVID vaccination, theoretically, an employer could be on the hook for paying the employee for sick leave through the resolution of that illness. That may be something that we'll see some clarification on as we go through this process. I don't want anyone to fall asleep, and I want to have time for questions. So please look at the regulations themselves for the specific requirements on how you have to push this out and train your employees, the records that you have to keep. There's a big record keeping obligation here, and the things that trigger a reporting obligation to OSHA. Now, talked about anti-retaliation, big liability if you are perceived to retaliate against anyone. So be very careful. Just like you would with an employee who's been out on FMLA, if you have somebody who's been medically isolated through this OSHA program, be aware that taking adverse actions against that person, even if they're totally unrelated, the temporal relationship may give the employee a claim under this that you're going to have to go to the trouble of defending and rebutting to show that you didn't have an improper motive. And before we go to questions, I will just clarify real quick. As I mentioned, the vast majority of this stuff becomes enforceable on July 5th. it'll be faster for me to tell you the things that don't become enforceable on July 5th. So you have until July 21st to install the physical barriers at workstations where employees can't remain physically distant, to make those adjustments to ensure on-site ventilation, and to push out your employee COVID-19 risk and mitigation training. Other than that, everything else that we've talked about today has to be in place by July 5th. And at this point, I will move over to some questions with the rest of our time.
Fantastic. Thank you very much, Meg, for covering a lot of ground and potentially a lot of concerning ground for the audience, I'm sure. We do have some time for Q&A, and I know a lot of the presentation may have conjured up some questions for the audience. So we encourage you to use that chat function. The other opportunity, maybe Meg, if you want to discontinue sharing your screen, if we go to gallery view, then we might be able to go ahead and have folks unmute or raise their hand if they want to ask a question.
Okay, how's that?
That's perfect. So there's a question. There's a question that's been submitted already through chat. Do fully vaccinated employees still need to work separated by 5 or 6 feet or have a barrier?
Yes, and so I am looking for the answer to that question right now to make sure that I am giving you exactly the right answer here. So it does not have an exception for vaccinated employees on the face of this. It just says at each fixed work location outside of direct patient care areas where each employee is not separated from all other people by at least 6 feet of distance, you must have cleanable or disposable solid barriers, except where you can demonstrate the barriers would not be feasible. They have to be sized and located to block face-to-face pathways between individuals based on where each person would normally stand or sit. They may have a pass-through space at the bottom for objects and merchandise, and they have a footnote that says physical barriers are not required in direct patient care areas or resident rooms. So, has OSHA provided a template for the policy that should be put into place? Policies, a number of policies here, and no, they have not. Trying to find, we did have some sample documents in here, but not much. Yeah, so they don't provide any sample documents at this point. I will say another thing that I didn't go into depth is there's a separate subsection of these OSHA documents called the Mini Respiratory Protection Program that really goes down into the weeds of respirator usage in covered environments. So you will want to look at that as well.
Meg, will you cover quickly for me? One of the key areas will be whether our members have to comply or not based on their situation. It was stated that one of the exceptions was that you're screening all non-employees that come in. Do they define what screening is at all?
They don't. You know, I think what I would recommend, well,
I would assume
screening means asking questions to determine whether a person is COVID-19 positive or has symptoms of COVID-19.
Okay.
And and as we talked about earlier, they've defined symptoms of COVID-19 as that broader laundry list of non-specific things that most of us probably have at, you know, at least once a week.
Gotcha. So if we meet that threshold where we don't have to comply, if you're in a small practice, you're screening all non-employees that come in and meet the other requirements, then all the other requirements are there. You don't have to comply with them, but do they set precedents in any way that you could be exposed to liability in other areas of law if you decide to just say, I'm going to screen all non-employees and just not worry about the other requirements that OSHA's laid out?
I think, and it might help real quick if you don't mind if I share my screen again, because I
Sure.
do have this, now that I don't need to get back to my presentation, I will show you this handy dandy flow chart that they've given us. So is your workplace is somebody providing healthcare services? If the answer is yes, then you get to that second provision about, is it a non-hospital ambulatory care setting? And are all non-employees screened prior to entry? And do you make anyone who screens positive not come in? If you meet those criteria, you don't have to comply.
So that is a pretty big out from all the other requirements, which is why I was asking if some of the other requirements around PPE and all the other things would set up. Should practices be considering some of those other measures, even if they do fall into this exception where they don't have to comply with the OSHA component of it?
Yes, I think that's exactly right, because you've got, this is really just OSHA coming in, a year and a half into this situation and imposing its own concrete standards and expectations. It doesn't get you off the hook for exercising reasonable care. And that's a kind of a common law duty that everybody has. So the things that everybody was already doing to mitigate COVID risk in work environments, you should continue to do those things, even if you're not required to comply with this. But I think it gives you a lot more flexibility in terms of looking at guidance that's coming out from the CDC and reacting to the way that things are evolving, both in your individual workplace and in the community that you were in. For example, even if you don't qualify as every single employee that we employ is fully vaccinated, if you are a physician office that does not have to comply with this emergency temporary standard because of your the nature of your practice, then you may decide that you don't want to require employees to wear face masks all the time, or to have barriers between workstations, or something like that. If you have a herd immunity going in your office. So it just gives you a lot more flexibility to do what makes sense for your individual situation. Frog in my throat. I would screen positive as a suspected COVID-19 patient right now.
There's a few other questions that have been put in chat as well.
Okay, let me stop sharing this now.
That's right.
But that flow chart is in everybody's materials, and it is a nice kind of graphic way to look through it. Would I define nursing stations as non-patient care areas? I think that really depends on the physical location and the physical layout of your space. If it's similar to an emergency room type layout where you've got bays around and you've got a nursing station that's very close by so that patients can be seen from the nurse's station, that's probably close to a patient care area, or it is a patient care area. But if we're talking about an area that is around the corner, that is, to use the ironically undefined term of well-defined space that OSHA uses, if it's a well-defined space that's separate from your patient care areas, then I think you can treat it as a non-patient care area. I have a question about an example with an EMS worker. Does the standard apply to firefighters? I think that it probably does not, because, well, it's a good question, and I suppose it's a little bit nuanced. It does not apply to locations in which first aid is rendered by non-licensed healthcare providers, non-healthcare provider employees. So firefighters have substantial first aid training, but most of them are not licensed healthcare providers. If you have firefighters who are also EMTs, I think you maybe have a different analysis. The next question, Fraser, do you want me to just keep working my way down?
Sure. I was trying to go through them as well.
Okay. If we don't have barriers, but employees are wearing masks, is that okay? No. The OSHA regulation says that if you cannot distance people at least 6 feet, you have to provide barriers. So that's a good example of an area in which you're kind of being held to a different standard that is going to remain in place based on what OSHA is putting in this publication.
And again, Meg, if it's a small practice that is screening everybody and meeting that first exemption, they wouldn't need to put up physical barriers, right? Since that's not a CDC requirement.
That is correct, exactly. So this is, all of these nuances are only related to people who have to comply, or practices that have to comply with these standards based on the flow chart. So assuming that you don't qualify for an exemption. If fully vaccinated, do we still need to do the full PPE? If you qualify for the fully vaccinated exception, you do not. But I don't believe that the standards say that you can allow an employee who is fully vaccinated to forego PPE. So there are, as I noted in the PowerPoint, a number of exceptions to the face mask requirement. So you have to make sure everybody's wearing a face mask, except if an employee is alone in a room, if they're eating and drinking in the workplace, provided that they're at least 6 feet away from everybody else, or they have a physical barrier, when they are wearing respiratory protection in keeping with one of the other provisions, when it's important to see a person's mouth, like someone who's deaf, and conditions don't permit a face mask constructed of clear plastic, in which case you have to supply a face shield instead. If an employee can't wear a face mask due to a medical disability or a religious belief, then you have to, so they say total exceptions must be provided for the narrow subset of persons with disabilities who cannot safely wear a face mask, including someone who can't independently remove it. The remaining portion of the subset may be exempted on a case-by-case basis. And in all situations, again, you have to provide a face shield if the condition, disability, or religious belief allows that. If you can show that a face mask presents a hazard of serious injury or death, the examples they give are arc flash, heat stress, or interfering with the safe operation of equipment, then you can provide a face shield instead. Any employee not wearing a face mask has to stay at least 6 feet away from everybody else unless it's not feasible, and they have to put their mask back on when they're finished. So it's, as I mentioned, quite detailed.
Yeah, Meg, what we might do, because a number of questions are still coming in, and of course we want to be respectful of your time, and we could ask questions all day long. What I did is just save the chat. So if it's all right with you, we'll get all the questions that have been submitted and provide some responses back to those questions that have been submitted. I did want you to cover, and before we let you have some final comments before we go, just wanted your thoughts on how long these regulations are going to stay in effect, because one of the questions was, what happens when a COVID pandemic emergency ends? What should we expect as far as the timeline for when these are going to still be in play moving forward?
Your guess is as good as mine.
Okay.
Honestly, it's a little bit surprising that we're in this position, because OSHA is only authorized to issue an emergency temporary standard when there is a sudden suddenly occurring crisis that presents an imminent risk of death to employees if OSHA doesn't provide emergency instructions. And since we were already a year and a half into this pandemic, it doesn't seem that we would meet that test. So I would not be at all surprised if we don't see some federal litigation going on over the implementation of these standards and some of their content, and whether it's appropriate for them to be rolled out and enforced immediately in this way. But for the time being, I think we're going to be stuck with them. And I guess the good news is that at some point we will be able to say that there's no reasonable expectation of any COVID-19 patients being present. And so I think that's one of the outs in the regulation as well.
Okay. Thanks, that's great. Yeah, we've got some additional questions coming in. So I will follow up with the chat with you if that's all right.
Yes, absolutely.
So we can provide a response. But do I have any closing thoughts for us before we conclude the webinar?
No, I hope that nobody has been driven to panic or to drink. It's hopefully for many healthcare providers, because of the nature of your practice, you won't have to comply with this stuff. And, you know, it's frustrating to have these regulatory standards imposed on you, but many of the things are close to things that providers are doing anyway. So I appreciate the chance to follow up with the chat questions kind of by email, because many of them are nuanced enough that I need to go back through the regulation to make sure that I'm comfortable in giving an accurate answer. Anybody who would like to email me a question, even if they didn't get it into the chat, is absolutely welcome to do so. I think Fraser has my email address. Fraser, should I mention it, or maybe I'll put it in the chat here?
Yeah, you can put it in the chat and we'll include it in the documents that we send out. We'll send a copy of your bio that we have that has your email address in there.
So I'm sending this, and if you did not get a chance to submit your question in the chat, or you think of something later, please feel free to send me an email about it. I'll be happy to look back at the regulation and think about your question and follow up.
Fantastic. And again, on behalf of all our members, thanks so much for sharing this material tonight. It was very timely and great information. So we appreciate, Meg, you doing that for us this evening.
Well, thanks for not shooting the messenger.
No, we're all in it together, I guess. Meg, thanks so much. And for everybody, this will conclude tonight's program. So thanks very much for joining us. Look for an email from us with the additional supporting documents, the bio and the recording from tonight as well. So thank you all very much and hope you have a great evening.
Everybody.